Hello, everyone. Thank you so much for joining us today. I'm Demet Toprak from University of Washington Seattle Children's Hospital, and I'm one of the moderators for today's ATS Peace Assembly webinar for the discussion on how to support international medical graduates and some tools that might be useful for recruitment and retention. I hope your day is going well so far. So my co-moderator, Dr. Fernando Urrego, and I will be having this honor to be part of this important and very meaningful webinar today. And we would like to thank the ATS Peace Assembly, our DEI advisory group, leadership, and members who supported us for today's webinar. We would also like to thank our panelists who are joining us today and you audience for being here and taking some time out of your day. I would also like to extend a thank you to Samantha Carpin for her technical help for today's presentation. So we would like to start with some numbers. So the American Medical Association provides some data about available residency positions. And as you can see, this number is coming actually from 2023 FRIDA website. And despite the recent match results, actually, these numbers are still not updated. So I will just present these numbers for now. There are more than 60,000 first-year residency positions across the United States. And as you can see, internal medicine has been having roughly about 13,000 positions, followed by family medicine, and pediatrics comes in third place with about roughly 3,400 first-year positions. So some statistics from the American Board of Pediatrics website as of March 2025 and where the international medical graduates stand in between the workforce in the United States. The total number of first-year pediatric residents, as you can see, is actually increased significantly since 2009, and especially since 2013 by roughly by 12% over, as you can see, it's increased from 2013 to 2023 by 12%, which is about 1% of annual change. But when you look at the numbers of IMGs, there were proportionally fewer first-year residents. The total number is about the same, but the proportion is about lower. So roughly a decrease from 23%. This slide presents the pediatric subspecialty data for all fellowship recruits across the United States. The total number of first-year fellows in the pediatric subspecialties has grown by almost 30% over the 10 years, from 2013 to 2023 in particular, which is actually a positive impact, especially considering all the gaps that we have in pediatric subspecialty care. And there's significant variation by subspecialty in the number of total fellows and increase over time. But when you break it down to look at IMG recruitment for subspecialties, there were still proportionally fewer first-year fellows who were international graduates in 2023 at 28%, when compared to 2009, when it was 34%. So for the Peace Pulm positions, there's a similar trend. While the overall total number of fellowship positions has increased, the proportion of IMGs actually has been fluctuating and might have been a little bit decreased actually over the years. So these are all the pediatric pulmonary fellowship programs across the country that are, and you can see actually a lot of these are concentrated in the Northeast, Midwest, and the South region. And as of June 2023, there were 194 filled positions across 57 pediatric pulmonary fellowship programs. Again, so these are still numbers from the American Board of Pediatrics, and as we just mentioned, the numbers are fluctuating between subspecialties for the number of total fellows and for the increase and decrease over the time. For pediatric pulmonary medicine, in 2009, there were 57 fellows, for instance. There has been like a little decrease actually in 2017, then it went back up again in 2018 to 70 fellows. And then in 2023, roughly there were 71 fellows reported as first years. And just to give you an idea, on the AMA FRIDA website, actually the total number of advertised pediatric pulmonary fellowship positions are at 80. So that means actually roughly about 9 to 10 positions every year go unfilled for pediatric pulmonary medicine. especially, when we think about the particular need for pediatric pulmonary medicine, this is over the years accumulating quite a bit, and it's very important. Now, thinking that a lot of it might have been related to visa restrictions per state, I'm going to go back to internal medicine and see actually how it looks for internal medicine and their subspecialties. Data from American Board of Internal Medicine releases results for third-year internal medicine residents, and you can see actually they're quite parallel and very close to each other, roughly a little bit above 40%. And the IMGs and the US graduate numbers are very close to each other. So very different from pediatric specialty and subspecialty. And the numbers for internal medicine residency does reflect actually today's subspecialties. Again, a little bit less this time for subspecialty IMG trainees, but still very close and not less than 40%. Obviously, these numbers, whether it's for internal medicine or for pediatrics, actually, it is including all types of institutions, whether it's an academic center, training institution, or it's a community hospital. But these are global and total numbers. So the lower number for pediatrics is not necessarily solely related to visa restrictions, looks like. So when a foreign-born IMG applies to a training program, there are potential questions surrounding this. And this starting with the ARIS package, certification and credentials, and can continue for years until the hiring process is an attending and beyond. And you can see, like with the ARIS package, credentials, legal issues, visas, and all these other items that you see on the list are sometimes really frustrating for program directors and search committees. So today, we would like to start with some presentations that will hopefully some of these questions, but feel free to type your questions in the chat box, and we can answer them to the best of our ability during the Q&A session. All of us as moderators and panelists are here today, and we would like to share our professional and personal knowledge and experience that we accumulated over the years. So it is my privilege to introduce our panelists today, who will be giving an overview of the most common issues that come up during recruitment and retention of international graduates, trainees, and faculty. We will start with legal support and advocacy, which will be discussed by Sarah Peterson. Sarah Peterson is practicing at Fragomen in immigration law practice. She's mainly focusing on employment-based immigration and uses her extensive experience and knowledge in immigration law for the recruitment and retention of international candidates. During her practice, she's collaborating with numerous medical centers and research facilities across the United States. After talking about legal support, we will talk about recruitment of IMG trainees and fellows. Dr. Ignacio Tapia will be with us today from the University of Miami, who is the chief of the Division of Pediatric Pulmonary Medicine and is also the Pediatric Pulmonary Fellowship Program Director. As the next topic, we will hear from Dr. Erick Forno. He is a professor of pediatrics and pediatric pulmonologist, and also the vice chair for clinical research in the Department of Pediatrics at Indiana University School of Medicine and Riley Children's Hospital. And last but not least, we will hear about building community and well-being from Dr. Nour Akil. She is a pediatric pulmonologist and associate program director of the Pediatric Pulmonary Fellowship at Duke University. So I would like to hand it over to Sarah going forward.
Great. Thank you, Demet. Let me get my slides up here. Okay, so as Demet told you, I practice employment-based immigration. I have spent the past 20 years working with international medical graduates in the clinics and healthcare centers, including academic medicine. And it's such a privilege to be with you all today. I truly believe that education is power. And so my objective over the next few minutes is to go pretty high level about what the immigration journey of an IMG looks like. I do presentations for IMGs all the time, and I usually spend an entire hour just talking about the immigration journey. So it'll be fairly high level. Then we'll talk a little bit about some state level actions that we're seeing happen across the country when it comes to IMGs, and then we'll end with advocacy. So what this slide really kind of goes through is the journey that an IMG goes through, right? First, they have to match. You all know that better than I do. I'm probably the only non-doctor on this call today. But there's the credentialing and the exams that everyone has to go through. And then any international medical graduate, whether they've practiced abroad for 20 years or they're just fresh out of medical school, they have to redo residency and subspecialization in the US. And usually the immigration status in which an IMG is doing this training, they're usually coming here in J1 status. J1 status is an intercultural trainee immigration status. It covers a variety of different occupations. But for our clinical IMGs, it comes with this 2-year home residence requirement at the end of the training. And so the US has this peculiar system where we're bringing highly talented and trained physicians in, we're training them ourselves, and then we're saying you have to go home for 2 years. And so we'll talk a little bit in a minute about some options to get over that 2-year home residence requirement. But, you know, I've been doing this for so long that when I started working with IMGs, most of the residency and fellowship programs are pretty flat or pretty even in terms of whether they would permit the IMG to train in J1 status or H-1B status. And H-1B status is just the most common ways that professionals work in the United States. Again, any occupation, it just has to be a professional level job. But over time, as the H-1B program started to get more complicated and more complex, the programs and more expensive, more and more programs started shifting away from H-1B status, and now most do require J-1 status for any international medical graduate to use to train in. O1 status is a status that's reserved for extraordinary ability. And so some programs will permit in special circumstances IMGs to train in O1 status, but by and large, most of these IMGs are training in the J1 status. So in the lifeline of the immigration journey, an IMG comes, they complete the residency and fellowship subspecialty training, and then they have to find a job, right? And so what that requires is you have to have a state medical license. I'm going to talk a little bit about advances in that space in a minute. But most of these jobs come with a 3-year service obligation to work in H-1B status, because in order to get a job, they have to waive that 2-year home residence requirement. So again, they come in J1, they do the training, but they inherently have a 2-year home residence requirement. Nothing waives that except for some of the programs I'm going to talk about in just a minute. Or these doctors have to go home, and then they have to come, they're available to come work in your communities. Once they're in your communities, if the employer doesn't sponsor the IMG for a green card or for permanent resident status, then they will have to go home at a certain point as well. So along in the journey, usually in most of my clients' medical practices, pretty quickly after the IMG is onboarded, they're going to start looking at the green card process because it's competitive. Demet was looking at the numbers and the unfilled positions, and it's really hard to retain doctors. And so it is a pretty aggressive green card pathway, at least in the current market. And I've listed a couple of different options that your IMGs are going to be looking at, or if you are an IMG, what you'll be looking at. But I don't have the time to go over them in any great detail, but just remember this J1 2-year home residence requirement is a really important step to get over in the journey of an IMG. So what this slide goes through is there are different options to waive that 2-year home residence requirement. For some of you in this room, maybe the most common one you've heard of is a Conrad State 30 waiver. And what that is a federal program that gives each state in the country up to 30 waiver slots each year. And they can allocate them. There's always a priority for primary care. But because the numbers of IMGs in primary care are usually pretty low comparatively to all the subspecialties, usually most subspecialists are getting these Conrad numbers. I've done a lot of advocacy in DC on this program, trying to get more numbers just because of the sheer supply and demand. Most of the big states, at least half of the states in the country, get well over 30 applications each year. And so then it really creates this tension of you have this IMG who's trained, they need this waiver, and if the state program is filled up, they might not have any other viable options. But there are a couple of different options that are somewhat likely or viable if these IMGs want to go to a specific geographic location. And so we've got a couple federal programs. We've got HHS, but that's clinical only. That's not going to help this group because we have subspecialists on the call. So that's not an option. But then there's a VAMC. I've been working with the VAMC my entire career, and they have very restrictive criteria and guidelines in terms of how they go about their program. So oftentimes it's really difficult for IMGs to actually work at the VA. If you're doing academic medicine, it's a good option. And I certainly do have clients that work at the VA. And these waivers include subspecialists, but it's a trickier program for a variety of different leadership-based priorities within the VA system. Then we have 4 different regional commissions. Regional commissions are a state-federal partnership, and they're based on geography. So for my entire career, we've had the Delta Regional Authority and the Southeast Crescent, the Delta Regional Authority and the Appalachian Regional Commission. These are in very, very underserved communities. And within the last 2 years, we just got the Southeast Crescent Regional Commission, which is great because if you want to practice in Florida, which I think Ignacio, you are in Miami, it's a great option for you. That's an option because the entire state of Florida is designated. And about a year ago, we got the Northern Border Regional Commission, and that's upstate New York. But these are geographically restricted areas. The nice thing about all of these is there's not a numerical cap. There's, as many people who apply who are eligible. It's a great option for you. So if anyone on the call is from Florida, remember the Southeast Crescent Regional Commission waiver, because that's a really good option for all of your employees. And then there's a couple that are personal to the physician themselves, but they require extreme hardship to a U.S. citizen spouse or child, or persecution. So it's sort of like an asylum standing, but they are viable options, at least currently. What I want to look at next is this, immigration hasn't changed for at least as long as I've been practicing, but what we've started to see are states trying to step in and fill the gaps to try to build out immigration programs because the federal government is not doing anything. And about a year and a half ago, 2 years ago, we saw Tennessee come to the table and introduce this. They started calling it alternative licensing models. And the idea was really to look at IMGs, because right now, in order to get licensure, you have to go, each state is different, but you have to go through at least 1, if not 3 years of accredited ACGME residency or, residency programs. So what Tennessee started looking at was, could we pull in IMGs who meet certain parameters, who have not gone into these accredited training programs, license them so we can build out access to care, particularly in rural or underserved communities. I think Tennessee's law is actually effective now. It was the first one that came out with it, but they're having a huge difficulty implementing the law. And I'll tell you why in just a minute. So after Tennessee came to the table, I started getting a lot of calls of, I can go to Tennessee and just work, no problem. Well, it's not that simple. Nothing ever is that simple. So lots of different states started to come up with different, their own versions of these additional licensing pathways. And so the FSMB, Intel, and ACGME, they developed this advisory commission on additional licensing models. And we all met in DC last May. And they were really looking at setting up guardrails and parameters so that if you have 50 different states in the country that are coming up with all these additional licensing models, is there a way to sort of harmonize them, or at least provide guidance in terms of best practices, sharing of information, and whatnot? And so the links on the bottom of the page really go through. There's a link to the states, and you can pull up whichever state you happen to be in and what the status of your particular state law may be. I've got the guidance on one of the slides. And then, there's another chart that I think will be helpful to you. But the problem with these additional licensing pathways, in Minnesota, we actually had one introduced last year. The Minnesota Medical Association actually opposed it because they were really worried about patient safety and the training of the physicians. So Minnesota took it back, and they actually just introduced another bill, which the MMA is now supporting because it thinks it has built out guardrails. But one of the key issues with these additional licensing models is if you have these IMGs who are not going through accredited training programs, they're not board eligible, and that really impacts reimbursement, privileging. There's a variety of different aspects that really prevent these physicians from practicing. In addition, immigration is a huge piece of it. That's why I was pulled in to sort of help people start thinking long-term. If you want to use these additional licensing models, what kind of systems and recruitment practices can you put into place now so as to position yourself to be able to sponsor these doctors? because it's pretty complicated. I could spend a lot of time talking about it, but there are ways that employers can best harmonize the immigration program and use these additional licensing models, but employers have to be really proactive and start working on it now. So if you happen to be from one of these states, take a look at the chart. It's out there, it's not going away. And it'll be really interesting to see how they evolve and if they have the desired impact because of some of these different limitations that I've talked about today. Okay, if you haven't noticed, I love advocacy. I spend a lot of time in DC. I was asked to talk about advocacy. And what I have on this slide is a couple of different ways that people can get involved. And remember, you don't have to be, we're not talking about voting. If you're an IMG, you can't vote. But there are different ways. You are still a constituent of your Senate and House locations, meaning you still can contact your senator and your representative and ask them to support a particular bill. So there are things you can do. On the top of the slide is the Conrad State 30 and Physician Access Reauthorization Act. This bill has been introduced for almost as long as I've been practicing. This is what I testified in the Senate to try to get them to pass, but it's still kicking around and it hasn't made any advances. It does a couple of other different things on a green card perspective, but if you want to do one step, calling your senator or emailing your senator and your representative on these bills, that's a great start. They're always bipartisan, meaning both sides of the aisle always support them. So that's one great thing to do. Then I list a couple of other bills that had kicked around. Remember, we're in a new season now with Congress. There's a new Congress since January. And so a lot of these bills, it's so early in the cycle that they haven't really gotten it's only been 70 some days since the new Congress took effect. But there's a Doctors in Our Borders Act. There's a Healthcare Workforce Resilience Act. There's another Doctors Act. I think politics are politics. So I would, again, focus you on the Conrad State 30 Act. I also want to mention regional commissions because we have 8 regional commissions in the U.S. Only 4 of them have active J-1 waiver programs. This is a longer term process, and given everything that's going on in the federal government right now with cuts, which I know you are all dealing with outside of immigration just generally, it'll be interesting to see what the future of those programs look like as well. But because they're state-federal partnerships, my hope is that we continue to have active and viable pathways for our IMGs through the regional commissions. But it's certainly something I'm keeping my eye on and happy to talk with any of you about it. The last thing I will say is I love to educate. I am going to be doing a J1 presentation with Intel in April. If any of you are interested in getting a more in-depth sort of what does the immigration process look like, reach out to me. I'll share the information. I also do presentations to different organizations and centers all the time. So, and I'm happy to take any questions at the end. Thank you.
Thank you, Sarah. We really appreciate it, and we'll have a lot of questions, I'm sure, at the end. I think we're going to turn it to Dr. Tapia, Ignacio Tapia from the University of Miami to talk about recruitment of fellows and faculty.
Thank you very much. So
Ignacio.
thank you. I don't have slides for this. I will talk on top of my head, and it's important that we make the difference between IMG and FMG. So IMG is international medical graduate that can be a US citizen, for example, who attended medical school outside of the United States. And foreign medical graduate can be a person who is not a citizen of the United States, who may or may not have attended medical school in the United States, or most likely abroad. So when you are not a US citizen, there are different hurdles that need to happen. Those international medical graduates who are US citizens, it's not so complicated to hire them because actually there's no visa restrictions or there's no grant restrictions, as Erick will touch upon after that. Those who are not citizens, then we have to see in which process of the visa are, as was recently presented, and what is their long-term career plan. Because many of them, for example, if you are in a J visa waiver, most likely that work would be mostly clinical. It's for underserved areas, depending on what category you fill in to do this J visa waiver. And as such, many times you're restricted, for example, at least during the 3 first years of your career, to have like a research career with significant protected time to boost your research productivity. So those conversations are very important to have it up front with the faculty. If they want to have the research career, that's totally fine, and we can support that, but with the understanding that the first 3 years have to fulfill the waiver. And during those 3 years, we can be strategic about carving some time, about increasing their productivity in academic output until they're sort of out of their waiver, and they can have more protected time and be able to apply to some foundations or NIH, as also Erick will be explaining as well. Something that is also important is the process of the green card, because most likely that's what we should be offering them. So right after when they do the waiver, or I think even you can start that a little bit earlier, is to have all the document in place for them to start their green card application. That can be sponsored by the institution, or they can be self-sponsored depending where they're at in their career. There's a different category also of foreign medical graduates that was touched upon in the previous presentation. If someone has already established career in their country of origin, if they are someone that are well-known academically, they have already finished their residency, fellowship, they have some academic output, there is the interest of the country to hire them here and of the institution. In that case, it is complicated, but it can be done. The waiver of the requirements or have US training can be accomplished. The institution has to work with the state medical board so that person can have a particular license that allow the person to work as a specialist in the institution only. That's not a big issue for the institution because most of us, we work only in one institution. However, that person is not board eligible or board certification, who can bring up issues with, with billing and insurance companies and things like that. But in certain places where you don't have many specialists, it's something that can be done. I know a couple of people who have done it. I know it's very difficult, but it's not impossible. It's something to consider. That is for faculty. Now, when you're hiring foreign medical trainees as fellows, it's also important to know in which visa they are. If they have a starting on the J visa, it's very unlikely that it could be switched to an H visa. Most of the time, they will have to continue their training on the J visa until they're done. If someone, for example, came on an H visa, an institution that does provide H visa, and they have to switch, does not provide H visa, and they have to switch to a J visa, really is not in their best interest to do so, because then they have to do the waiver. So in that case, there are certain cases in which people can do their waiver as a general pediatrician and then apply for fellowship. In this case, it works on our favor that there are not a lot of interest at this point, unfortunately, for pediatric pulmonary fellowship, and most likely they will be able to reapply once they have their age, which will pave their way if they want to stay in the same institution as faculty. So it's something that it's very important to have that honest conversation with the people and think what is in their best interest, in addition to your best interest that you want to hire someone for the position of fellowship, but that's important. Also, when you hire a foreign medical trainee, it's also important for them to know what are the foundations, for example, that can fund their scholarly work. Many times people think, oh, because I'm on this visa, I'm not eligible for anything. That is not true. Erick will talk about it. There's some foundations that can fund their work, and they can start an academic career, even though they need to put it on hold where they're doing their waiver. So it's something that is important. Also, something that is important is that they meet all the criteria for licensing and requirement. At the time that they get to us, most likely they will have taken step 3 because it's a requirement for the residencies. So that is not a problem, and they should be able to apply to a full-time medical licensing. So it would be less of a licensing hurdle from that point. And also it's important for them to have a structured mentorship, because they may have worked in the US system as residents, but when they're starting as fellows, they have a more independent role. So it's important that also we mentor them to what is expected from them. right? So to have the right communication tools, many times, according to different cultures, communication can be more vertical than horizontal, or things can be said with different words. So it's important that we work with them to make their work very easy, and they don't get extra stress that the training can give them anyway, with all these little things that come to get accustomed to a different culture. And the same with the attendings. Actually, I think that is very important to provide that mentorship, and if you want, that hand-holding initially until they can fly completely solo and go their way. So that's part of the cultural professional adaptation that is not reading in any curriculum, but actually so crucial to have a good communication with the team, especially around shared decision-making and patient autonomy that can lead to challenges in patient interaction. So that's important to have that. And also it's important to check implicit bias and institutional barriers that may impact the professional growth and career advancement of foreign medical graduates. So the solution for that would be to have a comprehensive onboarding and orientation. Typically, they do have that very scheduled, but this is the extra love that we have to provide as leaders. Peer support, network, and mentorship as well, if they compare with other IMGs or FMGs that are more advanced. The cultural competency that I mentioned, and also workshops of how medical documentation and communication overall is handled in the United States. And with that, I think I have used a lot of your time, so we can go to the next panelist.
Thank you, Dr. Tapia. Dr. Forno will talk to us about research and funding for IMGs and FMGs.
All right, thank you. Let me find the screen that I'm supposed to share. There we go. Can you guys see this okay?
Yes.
All right, excellent. So nothing that necessarily hasn't already been discussed to a certain degree, but the focus of what I want to focus today is specifically on those, as Ignacio mentioned, or those FMGs that are interested in following a research track as part of their career here in the US. And so this is something that, one second. This is something we already briefly looked at. I just wanted to highlight, right, this is for all fellowships, and how even though the proportion may be a little bit lower than 10 years ago, the numbers have increased, right? So there's about a 20% increase in the number of applicants. And then when we focus particularly in pediatric pulmonology, it's about 36 to 37%. So a substantial proportion of all of us are either an IMG or an FMG. And the reason why this is important is part of the goals of having a fellowship for pediatric subspecialties is to train people in the conduct of research, whether it's basic or clinical research, and the hope of advancing the field, not just directly through clinical care, but for future patients and populations by advancing science in the field. And so what we would like to see is that about 37% or more of the proportion of people doing research in pediatric pulmonology are also international or foreign medical graduates. As with everything, there are difficulties that people face coming from a different country, particularly if you are not a citizen. However, I think part of the reason for this, and I commend ATS and the Assembly of Pediatrics for putting this together, the better prepared we are with information to begin with, the more likely we're going to be successful. And so important to acknowledge that for research funding, including most of the programs that depend on T32 training grants for their fellowship, there is a requirement for people to be either US citizen, a non-citizen national, which is a small category, or to have permanent residence through a green card. And so this may affect people even if they don't necessarily plan to go into research as part of their career, but as part of their training, many fellowships depend on that for funding positions. That's not unsurmountable, but it's important to keep in mind when you're thinking of interviews for fellowship and having those conversations. And then the second part is really afterwards, right? Most federal funding, K-level grants, R01 grants, etc., will also require either citizenship or permanent residency. So just a couple of quick personal anecdotes. Of course, I was interested. I knew early on I wanted to do pediatric pulmonology, so I started talking to people early on, and there were a couple of programs where I, at that point, would have loved to stay as a fellow, including where I was doing residency, but they heavily depended on the T32, and so it made it difficult for me to be able to stay in that program. As I went through my interviews, I did talk to the division chiefs and the program directors very clearly early on about the limitation in terms of my citizenship, and so that's something that was important as I was trying to figure out where I was going to train. And then the same thing happened when I was ready for federal funding. It took me a while to get to this point where I was eligible even to apply for these grants. Now there are solutions, and so for training, for example, the CF Foundation has now allowed non-citizenship applicants to be funded for fellowship positions through their grants, as well as for research grants. And particularly for research, that is true also for other professional societies and private foundations. So there are ways to advance, whether it's through ATS or other societies or foundations, there's ways to make your research continue to grow until you get to the point where you can apply for federal funding. So what to do about this? It's harder. It's harder than for somebody who is a citizen. So it's important to prepare and do your homework. Like I said, I liked to have conversations early on, and I think particularly in pediatric pulmonology, certainly people who are part of ATS are a lot more aware, I think, than the general population in terms of chiefs and program directors knowing the details. But it's important. They may have very good intentions, but they have there's a lot of information to keep abreast on. And so it's up to you to be well informed, to reach out, to make sure that you draw attention to things they may not be aware of so that you can get the information. So for example, right, like I said, will they take you if you're not eligible for your T32? Can they fund you? Are they able to provide opportunities for research labs? Are you going to be able to do the research that you're interested in? Or are there conditions based on who is funding you of which labs are you able to participate or be part of for your research part of the fellowship? And so I think it's always, of course, to have a civil, polite conversation, but always important to talk up ahead of time. The other part, I think, afterwards, it's really how do you sustain your career, right? Once you're done with your training, you're going to have those 3 years where you need to work in a clinical area, in an underserved area for a full-time clinical position. And so I think it's important when you're thinking even in fellowship of your mentors, who are you going to talk to? Can they or are they able or interested in trying to help you through those 3 years to try to keep doing some research doing your waiver? So for instance, for me personally, I had conversations early on with my mentor, and since a lot of what I did for fellowship was data analysis, for the 3 years of my waiver, I continued to do analyses with the data that he had. It was a win-win situation, right? I wrote papers, kept my research going, and he had somebody else working on papers as well during 3 years, and so it was very productive. He eventually recruited me when I finished my waiver, so it was a really good relationship that we have to this date. And so again, it's not just the funding, but also planning ahead for your effort and your support. Again, your obligation during the waiver is going to be mainly clinical, but I think there are ways with conversations early on to try to provide some flexibility to keep doing some research. So that's all I had in terms of the research portion, and of course, happy to take questions afterwards. Thank you.
Thank you, Erick. That was great. We're going to move on to Dr. Akil, who once the FMG or the IMG gets accepted somewhere, it's getting them sort of to incorporate themselves within the community. So Dr. Akil from Duke will talk to us about building community and well-being.
Thank you. So yes, I will spend a few minutes talking about how to support our IMG, FMG fellows and how to ensure their well-being during the training period. I will say that the level of support that they will need will depend a lot on whether they're moving to the US for the first time to start their fellowship, or if they did their residency here or even some years of research here. But in either case, I think it's very helpful to get to know the IMG, FMG fellow, talk to them about their background, education background, prior experiences, whether clinical, research, languages they speak, what language or languages they studied medicine in their home country. That makes a big difference. Also, familiarizing ourselves with the type of visa they're on and the process ahead of them. Talking to them and inquiring about the existing support system. Do they have some support system here in the US, or is all the support system they have back home in their home country? Starting to talk to them early on about their future plans, career aspirations. Would they like to stay here in the US after fellowship to work, or do they see themselves going back home? Granted, these things might change, but I think talking about these things will help us get to know the fellow and maybe understand the level of support they need. If the fellow is moving to the US for the first time, resources about basic tasks that we really don't think about with other trainees, how to get a driver's license, how to get a social security card, how to open a bank account without credit score, what is the tax system in the US? All of these are very basic but very important and really very stressful to someone who is incoming and have no idea about them. Some programs, residency programs and fellowship programs, ask their fellows, IMG and FMG fellows who, after matching, if they can move to the US a couple weeks earlier to start working on some of these basic tasks. This time before the start date of the training is not going to be paid for. So some of them will be able to do it. Some of them will not be able to do it. But if they are able to and they get some of these things done, it will really help decrease their stress level as they start learning the medical system as well. Connecting the fellow after they match with GME personnel and International Affairs Office of the institution, even before the start date, as soon as they match, I think that is helpful in case they have any questions before or during the transition period. Longer division-specific orientation after the start date would also be helpful. More inpatient, outpatient shadowing time, focusing on note writing sessions, templates to try to increase their efficiency and documentation, which is very important in the US healthcare system and medicine compared maybe to other systems in other countries. Also talking about communication and communication tips. If English is not your first language, sometimes, especially initially, it is hard to transition or to know how and when to transition from medical language, medical jargon, we call it, or lay language. So starting to talk about these things and even providing them with lists of, well, if you want to say, pulmonologist, you can say lung doctor instead if you feel pulmonologist is a big word and the patient will not understand. Things like that might really help with the communication with their families and patients. And there's something that we also sometimes don't think about, but there are specific gaps, knowledge gaps that the IMG, FMG might have. These knowledge gaps are specific to practicing medicine in the US. A lot of these gaps come from the American history. So a lot of documentaries and sometimes movies, actually, good movies that explain the history behind this specific relationship between the healthcare system and this specific population. That will help them understand the patient populations they're going to be working with and helping that they might not been exposed to before. There are a lot of, not a lot, there are several acculturation resources online. This is an example that I like. It's on the AAMC website. It's open access. It's a group of workshops that the APD or PD can go over with their IMG, FMG fellow. And last but not least, I want to say that after that initial hard phase, it is very important to continue to support them. Even if we feel they're doing great, I think it's very important to continue with very strong mentorship and regular check-ins, to continue to provide them clear expectations and timely feedback, and remind them of the institution-specific bias reporting systems, and also paying attention to their well-being and burnout. I do want to say that a lot of the IMGs, FMGs will request less number of vacations, but longer vacations so that they can go back home and visit their families. So that puts them at a higher risk of burnout because they're getting less frequent breaks. So again, reminding them of the resources that the institution can provide, GME mental health and well-being resources that are available. And these are some resources. If an IMG program director or APD matched an IMG, FMG for the first time, or not necessarily for the first time, it is good to kind of familiarize ourselves with some resources and some papers and articles that are there, and they're actually really good. This is just a small number of them, but I would say training an IMG, FMG is different, and needs a little bit of knowledge on our behalf. And that's it. I think we have some time for questions.
Thank you so much, Nour. We want to open the floor for questions. If you guys have any questions, if you could just raise your hand, or we can read the questions that come through the chat. Dr. Perez?
Hey, how are you doing? Thank you for organizing this. I have a question for Sarah. I have a doctor that actually was born in China. I mean, she's a permanent resident or citizen from another country, but there's a lot of issues with like where you're born and where you're a citizen of. Like she's a citizen of Spain, but like her path to try to get to her green card is being challenging, especially with the new changes. So I don't know if you can comment a little bit more about like, you're born in India or China or some of these countries, even when you do an NIW or you try to do a perm, it's a very different time frame, and it creates a lot of stress. And along the same lines now, like the fact that if even you renew your H-1 visa can affect like when do you get your driver's license if you don't get the stamp, and can you get into like a new consulate or an embassy? And there's a lot of changes, and people are even afraid about leaving at this point. So I don't know if you have any comment about that or any suggestions.
Yeah, I mean, great questions. Everything with immigration is based on country of birth. So even if you have dual citizen employees, it's always based on their country of birth. Regarding, considerations, the time frame is longer, but the way that our system has evolved since the pandemic, there's delays for people from the rest of the world as well. So it's certainly longer for China and India. The takeaway from that perspective is for the programs, you want to be starting your green card process early, right? And so the final point is travel. We hear a lot of media. I actually teach an advanced immigration course at the University of Minnesota Law School, and we talk a lot about what can we expect. People are scared. We don't know, but so many people travel every day right now. I'm not terribly worried about international travel. If someone has a criminal issue, they're going to get caught up with it. But, I think right now I'm talking to my clients about risk if you travel and you have to apply for a visa because of the federal funding cuts that are impacting the Department of State and consulates abroad. Wait times are going to be longer. India, they just changed the way that people get their visas abroad, making it longer. So everything is just going to take longer. And so I don't think travel is impossible right now, but people need to be making smart decisions. And I think Nour was talking about, IMGs or FMGs taking longer periods of time, getting them to apply for the visa the day that they land back in the country. That's what I tell my clients. You can have the maximum time to actually get it processed and deal with delays. So there's a lot more to be said there. But hopefully I addressed kind of your big questions. Yeah.
Thank you, Sarah. Dr. Rivera?
Yes, thank you. Thank you so much for this presentation. It was really great. I have a question. I think it's for Sarah, but I think anyone possibly can answer. And I'm sorry if I missed this, but for the non-Conrad 30 state programs, are they also eligible for J1 visa waivers?
Yeah, and I apologize. I did such a high level. So I think I forget if it's Ignacio did a really good job of saying that all of the waivers that I have on the left side of the slides, and I can share the slides with you, they all have a 3-year clinical obligation for 40 hours a week. But one thing that I will add to what Erick said is almost every academic medical center in the United States is located in underserved communities and are eligible for the Conrad program or whatever geographic-based waivers. And so for my clients, I have a lot of academic medicine physicians. And so the way that you structure it is you're doing 40 hours a week clinical, and the research that you're doing is above and beyond as long as the H-1B petition, contemplates it and explains it. So research is not impossible. I think the more difficult parts are the funding aspects that Erick talked about. But with all of the J1 waivers that exist have that 3-year clinical obligation, except for the 2 that are personal, which is the persecution waiver and the hardship waivers.
Sarah, can I ask a question actually from the chat box?
Yeah.
Tanya put a question in. Can you discuss the pros and cons of the use of O visas as a path to higher faculty, which is also sometimes a very popular way of going that way?
I mean, look, O is a great option if you're someone of extraordinary ability. And so the nice thing about O is that it's pretty flexible. You originally get 3 years. Unless there's some sort of change in the employment, then you're stuck into these 1-year renewal cycles, and that can get burdensome and sort of take more time. So it's a little bit different than H-1B. But if you've got someone who's O1 eligible, there's not a lot of downfall, in my opinion.
Is there
and sometimes, go ahead.
It was more of a follow-up. Is there a concern about, getting a green card or not able to through an O?
Yeah, and I was going to follow up my comment, oftentimes O1 is used as sort of a stopgap. It's for your IMGs who are unable to get a J1 waiver. So they still have the 2-year home residence requirement. So then they get the O1 petition approved for them and they work in that. That's, you're going to have to get these, at least doctors who are in J1 status at some point, you're going to have to keep putting them in the J1 waiver cycle and transition them to H-1B. But if you have a doctor who is never in J1 status, O is a great option for you.
We have a lot of hands up, Dr. Gelfand and then Dr. Barthori.
Thank you. I had 2 questions. One is on that Conrad. If somebody applies and gets it, what are the next step? I guess 3 years work and then you can apply for a green card, or are there steps in between? And my second question is, I'm here in Dallas at UT Southwestern, and when it turns about when they talk about underserved area, it's where Texas is using where we're actually located. So I'm in a huge medical center that has, a fair amount of pediatric pulmonologists for this zip code. So they say we're not underserved, yet there's 600 people on our waiting list. If you go 15 miles away, those areas are underserved. How do we change the way they're thinking about there's still not enough of us and we really are underserved, so that we can potentially hire people who need an H-1 waiver?
Yeah, I mean, a lot of different ways to look at this. But, to get the designation changed, you can work through your government affairs offices, because that's just based on the data that's existent. So the Conrad program works like this. You have your J1 trainee, whether it's residency or it's going to be fellowships for this group. They get the J1 waiver. That just prevents them from going home for 2 years. Then the employer sponsors them for H-1B status, and then they work for the 3 years. For all of my clients, I'm always starting the green card process right away in that 3-year process, because the goal is that hopefully by the time they hit 3 years in 1 day, they're eligible to file for their actual green card application, because there's multiple steps in most green card processes. So getting the foundation laid during that first 3-year period, that clinical period, is really important. For your Indian and Chinese nationals, you're not at 3 years in 1 day is just not feasible. But for everyone else, as long as you're starting early enough, you probably can get to the point where they're filing for their green card application 3 years, 1 day. Regarding your question about demographics, where do you put people? These J1 waivers are based on everything in immigration is based on where the person sits. And so if you have facilities, if you could open a pediatric pulmonology facility that's in an underserved community, you could open a practice there, like if you have the resources and the bandwidth to do that. There is also, within a Conrad program, there are also 10 waiver slots. We call them flex slots. They're for doctors who aren't physically working in an underserved, so medically underserved or health professional shortage area. So they're not physically working in the area, but you can show that they're pulling patients from underserved area. The problem with Texas is it's so oversubscribed and competitive that those are the most difficult waivers to get. So probably for you specifically, and Andrew, you're looking at, could you find facilities, or could you locate a facility that's in an underserved community? And then, yeah, I mean, I think that's all I've got. The Regional Commission, we've been trying to get one in Texas for a long time. It's probably the farthest advanced, but it's years out still. So advocacy behind the Regional Commission that covers Texas is a great advo move for you as well. Because if you get a regional commission, then there's no limit on the numbers of waivers available each year. So for a state like Texas, that would be a big deal.
If you have a contact or something, I'd love to learn how to get in touch with those people.
Yeah, we can somehow. If you Google me on the website, you can find me. Just send me an email, and I'm happy to connect you.
Perfect. Thank you so much.
We need more allies in the fight. So yeah.
Dr. Rathori.
Yes, thank you so much. Excellent presentation. I appreciate you doing this. I may have missed it, but most of the discussion and presentations were focused on research careers. But the reality is that in subspecialists and pediatrics, especially right now, there are a lot of places that are looking for clinicians. And I think just to make sure everybody is clear, there is no Conrad 30 does not, as best of my understanding, does not look at research. They just look at underserved areas. So I think a lot of, as I think Dr. Galfan said, they have, 19 pulmonologists or something like that. They still can, 600 waiting list. So I think you just don't need to have people who are focused on research. The clinical need, actually, that was the purpose of Conrad 30, to meet the clinical needs. So I think let's not, a lot of the Children's Hospital do it because they are the focus. Now, the one thing I know folks have done is they have partnered with FQHCs. FQHCs are often in underserved area. So if you have a pulmonologist who's willing to do some primary care for a little while, that's a good way to get them in there. They'll do some primary care, there's some pulmonology. Some of these FQHCs have actually started specialty clinics in their FQHC. So I think just some ideas, Dr. Galfan, that there can be other ways you can do that and get these physicians into clinical practices where they can meet your needs, the community's needs, and also their own immigration needs.
Thank you.
I think we're, Dr. Perez, I think you had a question. You had your hand up. We're almost out of time, but.
No. It was already answered. I was just going to bring up the flex program. That's the way that I did it. And, like every state is different. Like this is quite interesting because there's timelines. Like you need to know exactly what is the timeline for each state, what each state requests as part of the contract, because every state has their own regulations and dates and so on. I did my waiver in DC. So again, it's different. And there are some that are easier than others. So you need to be aware. There are web pages, there's tons of information online. So depending on the state that you are.
Yeah, and again, I had such a restricted time frame. If it's helpful to you all to do just an immigration 101 in an hour, I'd be willing to do that because there's a lot of great questions, and I just didn't have the time to go into any depth at all. So.
And so I just want, I know we're running over the time, but just really quickly, right? The important thing here is to make sure that you're proactive as possible. I think it's great to see program directors and division chiefs here because there's a lot of information that keeps changing. But as an FMG or an IMG, it's in your best interest to get information early on. A lot of times it happens, right? You think you want to apply to somewhere and then they don't qualify as an underserved area for clinical work, or they've tried and it's really highly competitive, and so you're probably better off trying somewhere else. So it's important to have all those conversations early on. Most people in pediatric pulmonology will want to help. It's just incumbent upon each of us to try to provide as much information as we can.
So I want to thank everybody for coming on the call today. I'm sure we're going to try to set up a lot more of these because there's obviously a lot of questions and there's a lot to be done. So thank you, everybody.
Thank you so much.
Yeah.
Have a good night.
Thank you.
Thank you.